Good afternoon. Hello, this is Dr. Sascha A Jovanovic here from Los Angeles, from the Guide Institute. And we are going to help today a patient that has unfortunately fractured her front central incisor tooth, and our numeric number is 8. Interesting fact here is that our patient had an implant placed for a missing lateral incisor, which is number 7. So it's something that's a little bit more challenging than just a normal immediate tooth replacement, because we're going to have to also be very careful with the soft tissues and the bone next to number 7. So the implant is going to go in. Diagnostically, she's an excellent candidate for an immediate tooth replacement. So she has the full buccofacial bone present with no recession or resorption. She has the full marginal gingiva on number 8 present, and apically to the root there is sufficient bone to place an implant immediate. The implant we're choosing today is an engaging immediacy implant from Straumann, BLX, and the size we have chosen for her is an 3.75 or 4 by 12 or by 14. We planned for a 3.75 by 12, right? So we planned for a 3.75 by 12. Now I want to show you the presentation. The patient is healthy, clean, has a great maintenance. One of her family members is a dental professional and is taking really good care of her. So here's the presentation. You can see here the overall diagnostics. You can see that she has a really good marginal gingiva. And we have on the lateral incisor, you can see here the implant. This is like an 18-year-old, 17 or 18-year-old implant that shows really stable crestal bone. At that time we placed a zirconia abutment. You can see that. It's really well designed in a subgingival space, and the crown came directly on it, although the margin is right at the gingival crest. So this is like, we do it a little bit different today, but for those days this was like as perfect as it could be done. And you can see the long term is incredible because we're getting close to 20 years and the marginal gingiva is stable and the bone is stable and the crown is stable. Yep. We took an oral scan to be our base for the digital planning. You can see everything seems to be very healthy, no recessions, in good stable condition. Then here's the CT scan, where basically when you look specifically at this one, you can maybe zoom in on this one here. You'll notice that the buccal bone on the tooth is present, and that's probably one of the most important diagnostic tools that we use when we're having these kind of patients be decided if it's an immediate tooth replacement or not. Next to it, when you look at this one, that's your 18-year-old implant, long implant, and you can see beautifully here how the reconstructed bone, because she got a GBR procedure 18 years ago with autogenous bone and with Xenograft, with BioOs, and you can see how stable it is, 2+ millimeters on the buccal. Then here's the digital planning. So this was done here in-house using co-diagnostics, and you can see how the implant is positioned here, hugging basically the palatal wall. You're getting through the occlusal of the tooth, so it's a good screw retention will be possible, and also we're placing the implant into the apical bone for stability, and we're staying really free and clear of the buccal plate of bone. So that will be like a gap that we're developing of about 2+ millimeters that we're going to fill with some Xenograft. Then that's your exit. The left scan is flipped. So imagine this should be like left and right should be flipped. But you can see the exit, which gives, of course, the screw retention. And then on the right side, you'll see here the surgical guide that was designed here to help us with, in this case, we're doing a partially guided implant placement. And here is the guide that we print in-house using the Straumann printers. And you can see one of the guides is a 2.2 millimeter and the other one is a 2.8 millimeters. So we're ready to start. We gave the patient like buccal and palatal infiltration anesthesia. She's a very healthy patient, very stable, no medications. And we're using just infiltration anesthetic and local anesthetic. And as needed, we'll be reinforcing this. So we're ready to start. Good. Okay, open. And we're ready for the photo. I'm bone sounding, in this particular case, to about 4. That's 3. On the midfacial, where I'm looking for bone, we're at about 4. So most likely this implant will be at about 4 millimeters from the marginal gingiva. Interproximally, I got about 3. That's really healthy. Palatally, I'm bone sounding to about 3 or 4. So everything indicates that she has sufficient bone. Okay. Making first a sulcal incision. Patient had a root canal done on this tooth a long time ago. So I'm expecting this tooth to be pretty fragile. And where's the 15? The fracture is going all the way from the buccal towards the palatal. So it's quite an extensive fracture. Okay, so we've done this, we're ready for the piezo. I'll loosen the tooth a little bit with the piezo surgical tip. So for piezo surgery, we're using the Mectron device. This is like the most efficient as well as least invasive. So I'm going and trying to release the bone. I'm not going on the midfacial. Just going interproximal. And again, I have to be careful because I have the implant in number 7 position. Bone seems to have a normal consistency, not too dense. I'm just trying to get into the periodontal ligament space. A lot of irrigation, a lot of water. On the palatal, I'm going to go all around the tooth because the bone on the palate is thicker. You put a mirror there, so maybe you can pick it up a little bit in the mirror. Could be also a round mirror. The palate, just show you what I'm doing on the palate. Oh, here's the tooth. Okay. So let's see how the tooth is loosening. Okay. Yeah. A little bit of pressure. I'm putting the pressure on the central incisor. I'm trying not to go towards the lateral, which is the implant, and also the crown.
Good visual.
Okay. Need some light pressure there.
Just some light pressure, okay?
Trying with the forceps to be very careful not to touch the marginal buccal gingiva. Slight rotation. Trying to be very careful so we don't put any pressure on that buccal plate. There we go. Here's the root. And we can switch the piezo to, yeah. And you can see the damaged root. And came out in really nice one piece. Okay, first step went well. Now we have here the piezo. I'm using the round tip. So this will help me to just remove any of the soft tissue, fibers, as well as any kind of periodontal ligament fibers of the bone. And if there's any kind of inflammatory infiltrate, we'll remove that with the vibration of this piezo surgical device from Mectron, and also the irrigation obviously will remove everything. It's a root canal treated tooth, so the socket is probably pretty, let's say, dense. So we want to make sure that we got a lot of bleeding here, which will come. At this moment, it's still pretty minimal. But I'm scratching this socket, and then ultimately we'll perforate it, okay? Then we have a hand instrument, cleaning the inside of the buccal bone plate. But I'm doing this kind of gentle. Look, you see I got some fibers off here. Suction it. Because I don't want to put too much pressure on the buccal bone plate because it's very thin. You saw it on the CT scan. It's present, but it's thin. Okay, so that's good. Now we're going to examine the gingival margin, and you can see here it's completely intact gingival margin after the tooth extraction. And we of course want to maintain this. The thickness is, I mean, this is not a thin gingival biotype, so that's the first thing is good. But as you can see, it's still like very, very loose tissue. So if I would just leave this unsupported without any kind of support of a soft tissue graft, this will just collapse. You can see like there's no support at all here. So then I want to look at where the bone is, and I use the periodontal probe, and I'm going to be looking by sounding, and it looks like it's at about 4, right there. That's my mid-facial buccal bone crest. So the goal will be to place the implant at that level, at about 4 millimeters. On the palatal, it's about 5. So on the palatal, I got a little bit more tissue, and that's fine. So we got about 5, 4, yeah. And then in the proximal, we have a good bony housing. That's normal. Okay. There we go. So buccal bone is present, interproximal bone, and palatal bone. So here's my surgical guide. And we're going with 800 RPM. It's a pretty narrow space, so my handpiece is getting in the way, so I have to use a longer drill. You can see that the water is getting really nicely underneath the drill, so I have no problem with irrigation of this guided drilling. There we go. Perfect. First drill has been placed. I want to now check the drill position. Okay, mirror. So that's my, we planned the implant a little bit closer to the natural tooth than the lateral incisor, because the lateral incisor, as you know, is a dental implant, and we want to, occlusal, yeah. We want to kind of be a little bit away from that implant to preserve the buccal, sorry, the interproximal bone. So here's your, there we go. Okay, so I'm palatal enough, that's great. And look at the periodontal probe. This drill right now, periodontal probe, is, the marginal gingiva is at, I need to drill this to 16, because it's a 12 millimeter implant plus 4 gingival millimeter cuff, so it's at 16. It looks to be at about 16. That should be 16. Let's double check the drill. So right now we're already at 16. Let's go with the 2.8, and that will be our final drill. And here we go. It's a little step drill, as you can see at the bottom. It has a little bit smaller diameter, which is fine, so we get a little bit more compression there. And remember that we're dealing also with an implant that's a little bit tapered. The BLX is a little bit tapered, so okay, here we go. Okay, good. And the drill again. And the next thing is that we're going to go to the implant. So that's my 2.8 millimeter diameter, and you can see again, like I'm just making sure that we plant this a little bit closer to the natural tooth, just because the bony peak next to a natural tooth is always much more stable than a bony peak between or around an implant. So, okay, we'll show it as one second. Okay, I'm going to get back to the 2.2 for 1 second. On a 2.2 millimeter drill, I just want to make sure that I'm on depth. That's good. Yeah, it's good depth. Okay, I'm deep enough. Okay, good. So now we're going to go to the implant. So we're going from a 2.8 millimeter diameter drill to a 3.75 millimeter implant. So just show it with the okay. 3.75 is the SLA active, so it's the enhanced rough surface with a length of 12 millimeter. And it's the rock solid, which has approximately 85% titanium and 15% zirconia. Okay. We have made this gingival contour guide, as you can see, just in case that I would lose the marginal gingiva, because you never know. I have a plan A, which seems to be working out great right now. But if I, for some reason, had to go to plan B to make a flap elevation, you can see how we have made a surgical little guide so I know what the marginal gingiva is, and you can see that here. You can see how it duplicates the marginal gingiva on the number 9 and on the number 8. And so if I would have to raise the flap, I would have gone with my periodontal probe and placed the platform of the enhanced surface about 4 millimeters below this surgical guide. So that's my plan B. At this moment, I don't really need it because we're still in plan A and we're using the marginal gingiva as our guide. So here's the implant, SLA active, and yep. So you can see here, the body of this implant is about 3.5, and the threads, depending on where you have the threads, they're going to be like a little bit widening. It's not a really super engaging thread pattern yet because the implant is relatively narrow, but it will be hopefully engaging enough. And then we're going to the implant positioning right now. So now this will be done freehand, so I have to be careful, and I will obviously have to find the position I'm in. And there we go. Implant will help me a little bit to guide it. Okay, it's engaging.
2, 3, 4, 8, 13,
Right now we're stabilizing it. I'm like
14,
suction the buccal.
16, 18, 21.
I'm at 3 millimeters below. There we go. How are we doing?
30,
Okay, that's it.
30 next.
Okay. So we're in a good position. Do the occlusal view so you can see the implant. We're ready for the cover screw. Here's my implant. Mirror shot. Okay. 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 And before I do the bone graft, I will add a little cover screw in the implant. Just so I have the potential not to place any bone graft into the site. Okay. So I have this special instrument which I designed for U3D. It has like a carrier on one side so I can carry the bone graft into place. Okay, push it in. Push it in. Yep. And then on the other side it has like a condenser that I can condense the bone into the site. So this helps me like in one shot just by switching it around to place the bone.
Chin up just a little bit.
And same here. Now I always want to, this is a small particle size from the Xenograft from the BioOS. Important because it has the most amount of blood vessel ingrowth, but also it's important because I want to be able to move the bone really in an apical direction. So I backfill this. I do a little bit of bone graft and then I carry it into the space. Okay, you can give me some. And here's like something, for those of you who are Straumann users, this is the measurement tool from Straumann. And it's kind of a nice little thing because it's very atraumatic. It's a round ball. And it's small enough, about 1 millimeter to 2 millimeters, and I can use it to go into this gap. So it's very useful here as an instrument, so as a condenser. Okay, a little bit more bone. Not too much, a little bit, half of it, yeah. Yeah, okay. So this is my reinforcement of the gap. And obviously, the discussion can be like, could I use another type of bone graft material? And why does Xenograft, in my opinion, is the clear winner is because it's form stable. So obviously biocompatibility, other materials could be used as well, not worse, not better, but this one wins because I want to maintain that buccal bone plate as much as I can. So if I would add allograft in here, or tricalcium phosphate, it will resorb too quickly, and then I cannot maintain the contour, which is so important in this aesthetic position. So definitely my high preference, or like I would say almost only preference, is a Xenograft in this position. Of course, the site has to be clean. But you can see we're getting now already nice, clean blading. Okay. Mm-hmm. And it seems like that the gaps are filling up. You can probably still just get a little bit. But you see, this instrument that I'm using is not a bone plugger. It's officially a depth gauge from Straumann drilling system. So I'm just like using it as a condenser. Works really well. I think we're getting there. Now, a little bit extra xenograft in this space is not going to hurt because it's biocompatible, it's form stable. So even if it's laying a little bit in the soft tissue, it can hold its space. Okay, that's what. Next step is we're going to just look at that together. Here, okay, there we go. Now you can see why I need that healing cap. I completely obliterated the entry for my screwdriver with bone graft. So if I wouldn't have done this, the whole implant inside would be full with like Xenograft. Okay, so that's the screwdriver. Or is this wet? And here's the screw. Here's a scan body for the RB implant, or for this particular implant. And here you can see it, RBWB. Okay, that's my scan body. We're going to show you the scanner, which is like a normal 3-shape scanner, but we're just going to show it to you. We're going to show you the, okay, there we go, nice. So you can see the scanning. We're going to do the scanning in a moment. We're just prepared. We took already a pre-scan of the patient's teeth, and now we're actually just picking up the accurate implant body position. And so you can see this is really clean. I used to do this some years ago with like silicone impression material, and you can imagine that was quite messy. It was efficient as well when it's done good, but this is of course way cleaner and way more efficient. Also in our patient's case today, like you can probably pick up the gingival margin, like, you know, really well. So if you can go in and is there blood inside or it's clean inside? Okay, yeah, so the more you can take the impression, then the technician, we'll just give instructions to the technician to basically duplicate number 9. And in the subgingival space, they will just have to go very narrow.
Chin up for me just a bit. There we go.
And Rafi is already on standby. Okay. Okay. I want to see if I can put like an SRA in here, if possible.
If you put an SRA, I have to change the impression.
I know. We'll take 2 impressions,
okay.
if we can do it.
Okay.
I want to see, once I place the SRA, I want to see how deep it is. But I think I have enough space, because the implant is about 4 mils deeper, so.
That works.
Works? Okay, so we're good with our scan. I'll remove the scan body, and then I'm just waiting here. I'm doing something extra, which I normally wouldn't do, but like we're doing this especially here today. We're gonna try to see what abutment would be better for her, because obviously right now I'm setting her up for a tie base, temporary, but I will also look if I can do a titanium abutment just kind of as a final. So, and it's just straight, okay? Okay, that's my scan body. Okay, do a mirror shot. Here's my implant. Okay, we're ready. So now I will do another way, and this is like, you know, what we have discussed a lot in these kind of aesthetic type of implant indications, where we want to maintain the tissues in the most control is I will place an connectors, basically a short titanium abutment, black background. You can see that here. This is a 2.5 millimeters. So basically just imagine we're going to lengthen, we're going to lengthen the implant now. You can zoom in on the abutment. And this is a Straumann SRA, so abutment. We're going to insert it.
Okay, here we go.
And here we go to insertion. I need something to protect it. I don't want to lose it. Yeah. A little bit difficult to rotate. I'll just leave it there. It's bigger. Like that. Okay. Yeah, I think this is going to work. Because look at the positioning of that abutment. So this is kind of almost an, I don't know. This might be one of the first implant cases like this that we're doing like this. The concept of a connector using a screw retained abutment. So this, but this works really well because now we obviously are in a position that we're not going to connect the temporary to the implant. We're going to connect it 2.5 millimeters above the bone. So I just need to like screw it in a little bit more. Give me like a, and in case that in the end this might not be aesthetically feasible because the margin might be too coronal, I can always remove this and I can go back to the implant body. So, but if this works, then that's going to be great. Okay, hand tightening. Give me a little bit of torque. I want to torque this a little bit. Official torque is 35. I might not go as much as 35, so I don't want to over torque the implant. But I'm going to go to minimum 20. Okay. Okay, it's good. And ready for the scan body. So we're using the second scan body, but this is a different scan body than the previous one. So this is a scan body for the SRA or multi-unit. Okay. Okay, ready for the scan? Take your time. Next thing is I need a healing cap for the SRA. Make sure everything is good. Confirming that the scan is good. So just send like, you know, to Rafi both impressions. Okay.
Blue.
It'll change, I think. Just maybe just focus and come back. Sometimes it just needs.
I have here the depth is 4. So the thickness of my connective tissue graft or gingival graft has to be 4 millimeters in depth. That's what I call it. Then it can run from the mesial papilla to the distal papilla, so about half. So that's why I call it semilunar. And the thickness probably, if I can give it 2 millimeters, will be enough. So now I'm going to go towards a little bit the palatal area. So we're going to have to redirect the camera a little bit. I'm just wondering if we should put that in now or later. Yeah, we can do it now. Yeah, that's fine. Okay. That's good. That's about 4. I'm just testing the palate where I have about 4 millimeters. That looks to be sufficient. So right there at the second premolar, I have a nice amount. Okay. So I'm going to go to an 15C. Open wide as you can. Perfect. You okay?
Pain? Okay. She feels that.
Okay, let me have some anesthetic. I'm going with anesthetic around the area of my incision. Okay.
Okay. You okay? Okay. Just some pressure, okay?
Can you see that? Oh yeah, wow. Here's my, that's my little scarf or my little semi-lunar. Oh, it looks like a horseshoe.
The neck pillow.
Look. Plier. Now be careful that you don't suction it.
Can I get a gauze? Yes, just yes. That's the piece.
Hmm?
On the screen.
Oh.
Yeah, he's holding on to the graft.
I know, I'm sorry.
Yeah, thank you.
Okay. Okay, periodontal probe. Got it. And so this would be your soft tissue that you'll place on the facial and interproximal. Okay, let's show you how that looks. Here you see. And probably with some pressure and maybe one suture, you see it's already like, it's collapsing almost into a space. So we could probably do one suture here and that should be enough. Okay, we put pressure there. So that's the visual of our It's basically gingival graft with connective tissue. And that's like about 180 degrees. Thickness is about 3 to 4. So that will fit nicely into the space. Section there. Okay. Section there. And that's your graft. We're going to go with a 6-0, and but I'm going to use a really small needle. Okay, there we go. HR 1010, that's what it's called, but it's a really small needle. Go show the other one. As in comparison, that's like slightly larger, but I'm going to go with the small one. Okay. Right.
Let me know when to press.
Right now. Okay, that should be okay. Okay, here's the needle. And put the irrigation on that. Irrigation. More. Yeah, that's good. Perfect. We'll do one more. Okay, cut. You can do short. Okay. I'm gonna maybe do like a little holding suture here from the apical part. And I'll run it to the palate in this way. So it will keep my flap buccogingival margin against the abutment. And if it's going to be in the way tomorrow for my temporary, some anesthetic. If it's going to be in the way, I can cut this suture tomorrow. But it's just for today. Okay, put it on the distal. Yeah, perfect. Hold that, there's other suture on top of it, so it's not in the way, so it's not compressed. Suction there. And okay, so this suture, if needed, we can remove tomorrow, okay? Okay, that's your close-up. Great. You can see the soft tissue graft there. You can see my holding sutures, my 2 holding sutures. There we go. And the palate. Okay, yeah. Okay.
You want to do visual of the suture?
Yeah, sure.
Okay, she has, remember, chin.
Chin up a little bit more.
Chin up, more.
Okay. press on that because it's no, not with like an instrument. Yeah. Perfect.
Let me know.
Yeah. Pressing. Wait.
Press.
That's good. Did you take a photo of the palate?
No, we have to take it.
Okay.
And also the side
The what?
implant, the soft tissue inside.
Okay. Okay. I got it. On the palate. So we're completed here the procedure, and from my perspective, this will be a really good, let's say, healing, good outcome. We went through the steps which kind to be very atraumatic. You saw, first of all, the extraction was really, minimal invasive. We were able to maintain the marginal gingiva. We're able to maintain the buccal bone plate, and nothing broke. Yes. Then we cleaned out the socket. We had good bleeding. We placed the implant in the position that we had already planned digitally, so that worked out great. The BLX implant got really a nice stability, high torque, so sufficient for an immediate temporization. The Xenograft went in without any trouble into that gap between the buccal plate and the implant, and really a good condensation. We used about 0.25 gram for that. And then I took that semilunar connective tissue graft from the palate that we then placed like a scarf around the abutment. And then you saw two different scan bodies today that I took. I took one as a bone level, and a second one I took on an abutment level. So we'll see what is the best in the laboratory, but I really hope, fingers crossed, that it will be on top of the abutment so we don't have to go down to the implant. So overall, very good prognosis. Of course, patients to be really careful now with any kind of food intake, especially on the palate. So it should be liquid to soft food, and immediate temporization will happen like within 24 hours. And that will be then by tomorrow. Very happy.